Good afternoon, good morning, good evening. It will depend where you are now. So today we have a very nice case I want to share with you. Uh, and this is a patient that have 76 years old. Now I am with my good friend and my chief now, official chief, Professor Juan Manuel Alcibar. So I saw this patient few weeks ago, right? Because of an elevation of CA99. It was 76. This is just a slight elevation, to my opinion, to be honest. Okay, and no other symptoms. With exception some kind of bloating and some kind of dyspepsia. Nothing more. So we sent to make a MRI and we find out stones in the common bile duct, in the main pancreatic duct. So that's why this live transmission I wanted to share with you how to do an approach, in patients with pancreatic disease. Right? This is why I do it, and I will do this transmission in two parts. So this is the first part because this is the way that we do it here. I believe in other centers, like in France, with my good friends always, and my professors and mentors always. They do US first. US is very important uh, to evaluate, biliopancreatic disease for sure, and other kind of GI disease that we need to evaluate when we have this kind of patients. So the first thing is I am using a radial US from Pentax Medical. I want to say thank you to Pentax Medical Americas and globally because they has been supporting us a lot, too much. Um, so I want to see everything, right? So I like to see what is going on. I see here something that is just a finding, right? This is a lymph nodes, okay? So probably inflammatory lymph nodes, but we need to evaluate it, okay? This is in the mediastinum, right? So I don't see any other lesion here, and now I am in the stomach, in the gastric wall window. I'm sorry. So when I advance my US, I am using the radial. So the first thing that I want to see is the celiac trunk that I see here at 6 hour, okay? And then I can see, the splenic vessels, and then I see this is the main pancreatic duct, and I don't see too much the pancreas. So this is an atrophic, very important atrophic pancreas, and I see a lot of hyperechogenic areas here that we were discussing with Juan Manuel, okay? And I want to increase the image here because this is the way how we need to evaluate when we are using US. The details are very important, okay? So first I want to increase my image, and second I want to see, frame by frame what is going on here. So what I see is a very big dilation. You see here there is no pancreas, almost no pancreas. Is more Wilson than pancreas, right? Which is very rare. So it's 7.5 millimeters. This patient doesn't have pain. Doesn't. To be honest, there is no too much, symptoms in this patient, and it's because of MRI and the elevation that I send this patient to perform MRI, and now I am evaluating because of the results of the MRI. The other thing is that I see a lot of, like, a kind of a slush, we can say that. So sometimes this could be mucus, or this could be just pancreatic secretion, juice, right? But uh, this called me the attention, my attention, to be honest, first, and second, that the wall, in spite that having that this have, let's see, hyperechogenic areas, I don't see shadows. So probably are stones, probably are not, probably can be tissue, right? Then this is very interesting. That's why I am a little concerned of this. And also the other thing that I am evaluating now, that is very important to evaluate, that if we are talking about chronic pancreatitis, right, because of the dilation and probably stones here, but I don't see the shadows again, is the wall. The wall of the main pancreatic duct is very important to evaluate. You see here, so I don't see, I see some hypoechogenic areas like this one from the wall, and this is isoechogenic. Let's see like that, because this is hyperechogenic, this is isoechogenic, but this area is hypoechogenic. So in this case, to be honest, I believe this is um, something that my good friend Isaac Reichman also said. This is very important to be evaluated from inside, not just by US. US help us a lot during a lot of years, but nowadays we have cholangioscopes and we can go inside, right? And we have different sizes also of cholangioscope, so we need to see what is going on there inside, because this is like a small things, special things that we are not looking normally in this kind of patients. Okay, so I will advance a little bit more. You see again, so these areas, these small areas, and I don't see the shadow, the hyperechogenic areas, these ones, you see. So my suspicion is that probably this patient doesn't have just a chronic pancreatitis. One of the possibilities is the presence of another kind of disease. You know, it means a kind of mixed disease. One of these one is the presence of IPMN as disease, right? This is my suspicion, a little bit like thinking a little bit more, not just what we are doing and say, okay, this is a chronic pancreatitis, is finished, we need to treat. It's not about that. It's about to think and to evaluate very well by US, right? So I remember a lot one of my mentor, Bertrand Napoleon, that I have always in my mind, always explaining to me this kind of small alterations that we can see during US, right? And this is how technology makes us increase the or give a better report, a better diagnosis to our patient, right? So now I am trying to go to the head of the pancreas, right? And I want to see, I know that not all people like radial. I love radial because I was trained in radial also. So here now, what I am looking here is the head of the pancreas, but I see here a big stone, right? So I want to show you very well. I will increase the image, I will move the image, and I want to show the details, right? So I see here the head of the pancreas. This is a stone inside the main pancreatic duct that make a dilation of the secondary duct here, and this is the main pancreatic duct, and this is the shadow. This is a stone. Now I am sure that this is a stone. So this patient have a stone also in the head of the pancreas, but you can see the shadow there, and you can see the dilation. Here I'm doing a small movement to see very well. And here is the main pancreatic duct. So I see Again, let's see. Let's evaluate this image, right? What I see here is the main pancreatic duct. This is a secondary duct with a small, you know, like a kind of cystic lesion. Probably it's just dilation. We need to evaluate inside. But this is the main pancreatic duct. So I see here, this is normal because this is inflammation. And the inflammation we see like this, hyperechogenic with a band in the main pancreatic duct that, show me that this is inflammation. To the difference when we compare with the image that I saw in the body of the pancreas. So that's why I believe we need to evaluate by pancreatoscopy, right? This is a main indication. So I want to see the uncinate process of the pancreas. I don't see any alteration for the moment, so I'm okay. So I believe the situation of this is probably this is my suspicion. This is a chronic pancreatitis, but probably with an IPMN, and I need to evaluate inside just to confirm my suspicion, right? Or probably it's just a chronic pancreatitis, and I am saying I am looking too much, right? I am doing a false evaluation. So I will stop here my first part, okay? And I will come back to show you the pancreatoscopy, okay? Entonces cortamos la transmisión.